Well, good morning. Thank you very much for joining us. I see it's 10 o'clock Eastern Standard Time, and we'd love to get going promptly with our new series of webinars brought to you by our cardiac rehab program, and specifically the Cardiac College Online educational program. We have a number of individuals participating from across our different program classes, and we're delighted that you're able to join us for this morning. This session is about information about taking your heart medications. And, this is a topic that is often of interest to our participants, since we are all exposed to different kinds of medications during the course of our disease treatments and recovery. Here are a few ground rules for this series of educational seminars to remind us that these sessions really are for education only, rather than specific medical advice for you individually. We would invite you to connect with your healthcare provider for specific advice about your situation. We'll certainly take questions and answers, and that's often the most interesting part of these sessions. And I'll endeavor to address every question either today or in follow-up. But I may take the liberty of generalizing both the question and the response, and as opposed to getting into great depth about your individual situation. And you'll see you have the opportunity to ask a question and answer using this Zoom platform. If you click on that Q&A function and type in your question, I will be able to see them towards the end of this presentation, and we'll go through them in turn in the sequence that they are received. By the end of this session, we hope to cover off these items, and that by the end, you will know some reasonable information about the common classes of heart medications. What's good and what's bad about them? Why are you taking them? And why it might be important to keep taking them. In addition, we'll point to resources that can help you manage your medications and draw on the materials that are within the Cardiac College. One of the guidances that will be familiar to you is the invitation to go talk to your doctor, nurse practitioner, healthcare provider, or pharmacist about your medications, but you may have some more detail about which questions that you might want to ask. So here's a framework for medications in general, because I could go through a long list of different drug names, and there are hundreds of them that each of us might be exposed to. But medicines make sense when we put them into a framework. And this is a stylized pathologic slide of a coronary artery when the situation has gone bad. Now, I recognize not everyone has had a coronary artery event like a heart attack or an angioplasty or surgery. Some of us are on this call living with risk factors or other kinds of cardiovascular conditions. But for those of you who might be interested in how medications interact with the heart and the blood vessels, this is a reasonable framework for us to think about. Under typical circumstances, this large pink circle represents the artery. And when the artery is healthy, this is entirely open, and we should see nothing but blank space in the middle, because that represents the big tube where blood should be flowing. You'll see there's a number of different problems with this artery and plaque. This represents atherosclerosis or arterial sclerosis or hardening of the arteries, different terms for the same sort of thing, where we have in the middle here this large red oval shaped thing. This is a blood clot that is filling up this artery. So blood was not flowing. It in fact just stopped off here. This large red oval shaped clot is formed on top of this pink crescent-shaped moon here. And this represents a cholesterol plaque or atheroma or lipid core. Again, very different names for the same sort of process. This is fatty buildup over many, many, many years. And if that builds up to a sufficient kind of size where it is unstable and ruptures, it can cause this thrombus or blood clot to form. In addition, this artery is kind of dysfunctional, that in a young healthy artery, this is nice and elastic and it expands and contracts and blood flows through it quite nicely. But when it goes bad, then this artery is also dysfunctional. It gets stiff. It doesn't really move particularly well. So if we understand that there are these different kinds of pathologic problems, blood clotting, cholesterol building up, the artery walls being stiff and not functioning very well, and areas of instability and rupture, then we can think, well, there are medications in addition to all of the very good, quote, lifestyle things that we do that can help this situation enormously. And that's the framework that I'm going to turn to when we think about medications, as opposed to just presenting a list. So let's just start the story here with this blood clot, because many of you are taking medications that affect the blood system. We can start our conversation by thinking about what lives inside of our bloodstreams. Right now, you've got trillions of blood cells that are floating around through your blood system. If you happen to cut yourself for some reason and you see that red blood coming out, well, the reason that is red because you've got these lovely red colored cells that have the responsibility for carrying oxygen through our body. Red cells are called red blood cells. So that's a very friendly and simple name for them. We're also familiar with these cells here. In this slide, it's kind of colored purple, but in other kinds of settings, they may be more whitish in color. So they have that very special name of white blood cells. And white blood cells are very important to us for having one of its major functions of fighting infections. So important in this day and age when infections are rampant in our community. One of our lines of defenses is for these cells to get active and to fight off viruses or bacteria or other things. Now, the other kind of cell that floats around are these yellow ones here. And you can see that there's a whole bunch of them. In fact, they outnumber the red cells and the white cells. And these guys are called the platelets. Hopefully many of you are familiar with the platelets. They have a very special function in our bodies of sticking and preventing things from getting out of control if we get into cuts or injuries. This is a blown up picture further of what these resting platelets might look like. And if you kind of stare at them, you'll say, oh, I can kind of recognize this shape. It looks like what I might have had for breakfast if I ate a pancake or an omelet or a pita bread or something like that. And you'll see that there's a bunch of them and they can stack and unstack and just float around very innocently. They don't do much at rest. But very interestingly, when the platelet gets activated, because of a cut or an injury or some sort of trauma to the body, you'll see that these platelets can actually change their shape. They stick out fingers. The medical term for these fingers are called glycoprotein 2B3A receptors. Wow, that's something fancy. The point here is that the platelet can go from something flat to something three-dimensional, active, stick out its fingers. And then when the fingers get close to each other, you'll see here that they can start to stick to one another. That's what platelet activation looks like. And if we return to our model of what the artery looks like, it should be this nice big open tube. Here we're showing you again this crescent-shaped atheromatous half moon with a fibrous plaque on top of it. You'll see here, if it's a raw, kind of a rough or raw surface, then the platelets think, you know what? That looks like an irregular surface that I need to stick to. And the platelets can get quite activated to that surface, and they'll go through this process of actually going from flat to active to fingers to sticking across to each other. And they think that they are doing the right thing and doing a good job. But you can imagine if we get a whole bunch of these platelets getting activated and sticking here, that can start to block blood flow. This is why we pay so much attention to the blood system, and in particular to these little guys called platelets. Now, some of you might have had a procedure inside your artery, one that is called an angioplasty and a stent. So this represents the artery and long section. Here again, we see this crescent of fatty plaque that's built up here. This is the wire that was put across the plaque, the balloon that's shown in the white green, and the wavy kind of shiny stuff, that's the metal stent that is left behind there when the balloon and wire are withdrawn. Now, that's a marvelous technology. You can see that it's almost like scaffolding on a bridge that would hold this artery nice and open. But what happens when you leave a piece of metal in the artery or crush this plaque here is that that's kind of an internal injury. At least that's the way the platelets see it. And the platelets therefore like to stick to these sorts of things. So we are trying to open up arteries. We're trying to create a friendly situation, but in the process of manipulation, we can actually get these platelets excited. Now, this is a further blow up of what the platelets look like. And, gosh, there's this very complex kind of chemical pathway that's shown here. This is the platelet. These are the fingers that are sticking out from the platelets. And the point of this slide is that we're trying to tell you that the stimulation of the platelets to form, they just don't go like this on their own, that there's actually lots of chemical signaling that happens for a blood vessel to tell a platelet, look, I'm injured, I'm in trouble, please come help me out and be sticky. And one of the important signals that comes from the platelet itself is this thing called CO. In this case, this stands for a chemical called cyclooxygenase, CO, from inside the platelet. Why is this relevant? If we get a lot of CO that's activated from inside the platelet, you get lots of fingers formed, you get lots of platelets that stick together, and you get lots of sticking that forms inside the blood vessel. This happens in the setting of a heart attack. This can also happen in the setting where you got a fresh piece of metal that's dropped into your artery when an angioplasty occurs. So you'll ask the very smart question, well, if I know that this chemical is going to lead to this kind of blockage, surely there must be a medication that can help dampen down this signal so I don't get so much blockage forming on. And you all know the answer to how I can block this CO, because almost all of you are taking an anti-platelet, quote, blood thinning medication in the form of aspirin. Aspirin works really well. Aspirin, just a little baby aspirin, 81 milligrams per day, is very powerful because of that chemical kind of process inside the platelet. It blocks the cyclooxygenase, preventing the formation of the fingers and preventing the sticking happening. And in very large studies with hundreds of thousands of people, if you look at the risk of a bad thing happening, like a heart attack or a death, the orange bar represents people who took aspirin compared to the pink bar where people did not receive aspirin. They received a matching placebo or sugar pill. You'll see that there was about a 25% reduction in the number of individuals that had bad thing happening. So just a little baby aspirin works pretty well. But you'll see that it doesn't reduce the risk entirely. The risk doesn't go down to zero, but it is lowered substantially by just simply taking an aspirin. But platelets are stubborn. Platelets are like your kids in the car. And it's actually a very interesting analogy because we talked about platelets by sticking out their fingers and grabbing hold of each other. If any of you have had kids or grandkids sitting in the back of the car and you're going on a long drive, well, there's a tendency for kids to start to poke at one another, right? And they tend to stick out their hands, just like a platelet would. And if you tell kids in the back of the car, don't be so sticky, keep your hands to yourself, that might work for a little while. That's like giving your platelet an aspirin. But after a few minutes, the hands may come out again. And the platelets are exactly like that. So for us to really influence how platelets are interacting and sticky like that, we may have to tell them not only once, but tell them twice, don't be so sticky and keep your hands to yourself. So we've got different ways of working on the platelets. So if we come back to our little chemical model, we can tell the platelet don't get so sticky in the middle by feeding it some aspirin, and that reduces the production of this chemical called thromboxane to get the fingers to be less sticky. We can also work on the outside here for a different kind of chemical called ADP, or adenosine diphosphate. These are big words to say. Some of you, especially if you've had a heart attack or a stent placed, will be taking aspirin as one medication, but you may also be taking a second medication, such as clopidogrel or Plavix as its brand name, or ticagrelor or Brilinta as its other name. That's blocking the second signal. That's telling your kids twice, don't be so sticky. And this is why we will use more than one medication to try to thin out your blood, especially in sticky situations like this, where it is known that if you put in a piece of metal like a stent, and if you didn't do anything, then there is a tendency for blood to get sticky, platelets to get stuck on the surface of these stents and to form blood clots. So that is the story of why we may be taking combinations of medications like aspirin or clopidogrel, or aspirin and ticagrelor, for 6 to 12 months to prevent this thrombosis from happening. So every medication has good things, but every medication might also have some bad things associated with it as well. And if we were together in a room, we could roll up our sleeves and you could actually show me that you've got some bruises on your arms or your legs. And this is a common phenomenon, especially when you're taking these medications. So having these minor bruises that come up, if you bumped your elbow, or even if you didn't bump your elbow, you may get little bruises. And that is, while it's unsightly, is okay. It's not dangerous unto itself. Nor is minor bleeding for folks who might experience a little bit of dryness in your nose, especially in cold weather. And if you blow your nose and you get a little bit of blood, that's not such a big deal. Or if you nick your face when you're shaving and you get a little bit of bleeding, those are expected phenomenon when you're taking aspirin and the other medications. And in fact, in kind of a reverse psychology sort of way, you might say, well, if I get a bruise, or if I see that I'm bleeding a little bit more than I did before, well, that's actually a good sign, because that means that my medications are working very well to keep my blood sort of thin and keep the blood flowing down my arteries or past my stents. So those are the minor things. Now, we do need to be mindful, of course, that some people may have more severe bleeding. And if you're getting nosebleeds that are uncontrollable, or if you notice that there might be blood coming out in your bowel movements, or if they turn really dark, black, and smelly, that means that there's blood, bleeding that's happening internally. That's when we need to be worried and to give your healthcare provider a call to say, look, I'm really kind of worried about what's going on here. And some adjustments in medicines, or sometimes we give protective medications for the stomach so that we're less prone to developing stomach ulcers. And some of you are taking an antacid kind of medication for that reason. Okay, so that's the story of anti-platelet medications, aspirin, clopidogrel, ticagrelor, and others. And I see there's a couple of questions in the chat box, and we'll come back to those towards the end of this. So keep them coming, and we'll look at them. Okay, moving on to a second territory now. And it's worthwhile, since we've been chatting for almost 20 minutes, to say, do a quick check, do a pulse check. Just want to make sure everybody's heart is beating. I hope so. And your hearts are beating, and you don't really have to think about your heart beating, right? That it kind of goes on its own. It kind of goes automatically, or in terms of the nervous system labels, this is called the autonomic nervous system, that the heart just kind of beats and it goes and at a rate where we just don't have to think about it, that it's under automatic control. That's a really, really good thing. Now, there are situations that make the heart go faster, and there are situations where the heart goes slower as well. And that's where our next category of medications comes to discussion. That many of us are taking these medications that belong to the family of beta blockers. You'll recognize beta blockers because they end in the letters LOL. Nothing funny about them necessarily. That's just the convention for them. So medicines such as atenolol, metoprolol, bisoprolol, you'll see that there is this pattern of the LOL kinds of medications. And they are called beta blockers because they are blocking something called a beta receptor that sits on the heart and in other organs in the body. When you block the beta receptor of the heart, it slows things down. Why is this important? Well, going back to this automatic or autonomic nervous system that we are all familiar with, that we have this kind of wiring for fight or flight. So if we imagine that we have to fight a bear, if you can see this close up, you can see this is a spitting bear, very scary. And if you happen to encounter a bear in your backyard or in your walk or wherever you might be, that the autonomic nervous system will tell us this is a frightening situation. I'm going to pump out this chemical called adrenaline into our bloodstream, and very, very rapidly, when the adrenaline interacts with the beta receptor on the heart, it makes it go faster. I think you know this, that when you're nervous, anxious, or getting ready to fight something or run away from something, the heart rate goes up, blood pressure goes up, and that's a good survival instinct. However, if we're in the medical situation, there are no bears involved, but you just had a heart attack or you just had a surgery and you may be lying in a hospital bed or intensive care unit, well, this is also kind of a frightening situation. And we may have lots of adrenaline kicking up, getting us ready to fight something or run away from something. It's the same kind of syndrome. And you can imagine that this is playing undue stress on the heart. So if we can dampen this down, this would be a nice idea. And this is the role for the beta blocker medications, not so much for the bear, but when we are trying to recover from bad events that have affected our hearts, it might be nicer to have lower heartbeats and lower blood pressures where things are just calmer. And if we can create that kind of system, that hormonal system in the body, then this is a really good thing. Reduce the heart rate, reduce the blood pressure, reduce the work of the heart, reduce the stress. And if you can do that over the next kind of course of months and or years, what's been shown, especially if you've experienced a heart attack event, some stress and damage to the heart, then the chance of experiencing a second heart attack or irregular rapid heartbeats goes down substantially by use of these medications. So that's why you may be on a beta blocker medication, even if there wasn't a problem with your heart rate or blood pressure beforehand, that bringing things down may allow for the opportunity for the system to be even calmer. Every medicine is good. Every medicine may also be bad as well. And some of you may have experienced this, that if you're taking one of these LOL beta blocker drugs, you may feel like a turtle. You may feel like you've been slowed down, like with your heart being so slow and your blood pressure being very low, that you may also feel kind of slow, low energy. If you've got this kind of tendency to asthma, some people experience more difficulty with breathing related to the asthma. Because of blockade of these beta receptors elsewhere in the body, we may lose our ability to respond to low blood sugar or the signs of low blood sugar, because those are typically sympathetic, adrenaline-driven kinds of things. And we may feel tired. It may interrupt our sleep. It may lower our mood as well. So if you are feeling this way, that you are just so dragged out, that's worth discussing with your healthcare provider as well, because sometimes lowering the dose of these medicines or changing one for another may make the difference. So the positive is we might lower your chance of having a heart attack or lowering your chance of having very irregular heartbeats. But the other side might be coping with these kind of dragged out feelings. So finding the balance would be very helpful there. Okay, next up, we've talked about the blood clotting in the middle, and we've talked about the heart beating around it. Let's think about the cholesterol plaque, because we said that's one of the things that's giving us angst or problem. This is one of the underlying things for us that builds up over time. So the question that we'll ask us, or the physiology that we'll review together, is what happens with cholesterol in our body? Why is it there? And it reminds us that cholesterol can come to us from a couple different ways. One way that we often focus on is, I'm going to work on my diet and reduce the amount of cholesterol that I eat. And that's really important. But about 25% of cholesterol actually comes from the food that we eat, which means that we are wired such that 75% of the cholesterol inside of us is actually made by us inside of this big organ called the liver. So why are we so committed to this? Well, cholesterol is important. It's one of the building blocks for most of the cells in our body. Like the membranes are the outside packaging of most of the cells in our body. Cholesterol is useful for making important hormones like estrogen and testosterone. And it's important for some of the vitamins and the bile acids that come out of the gallbladder to help with digestion. So cholesterol is all over our bodies and it's made by our bodies. But the fact of the matter is that when we are in a situation where we can eat as much cholesterol as we want and we can produce as much cholesterol as we want, well, there's a net excess that builds up over years and years. And when the liver is producing all of this cholesterol by putting these building blocks together, that the net excess actually ends up being deposited in the arteries of our walls. And that's the crescent moon that we've seen. This is the normal state for us. And clearly, if this has been happening year after year, decade after decade, then we're building up things that don't belong there. So if we understand this, we can start to ask the questions that, given that I've had some kind of vascular event or I'm at risk for one, is there something that I can do to turn around this situation? Well, if I look at the pathway for cholesterol production and I break it down to products, well, this is very similar to what we've been thinking about for the platelets or the beta blockers. If I understand where things are working, well, maybe I can design a medication to block this. And very interestingly, about 30 to 40 years ago, folks discovered, well, this is one of the key steps. This is like one of the key factories in cholesterol production. And if I can block that pathway, if I can block that factory, then I can have less cholesterol produced. And in fact, one of these kinds of steps we can block with these medications called statins. The long name for statin is actually HMG-CoA reductase inhibitor. That's very long, so we often just use the word statin, which is a made-up word in the last decade, frankly, just to describe blockade of this pathway. The net effect of that is that we can reduce the levels of cholesterol that are produced and floating around by about 50%. And by doing so, we can hopefully reduce some of this deposition and, in fact, try to turn this around so we don't deposit cholesterol anymore into our arteries. We start to pull it out of the arteries. That's the exciting part of this, because we've said that we need some cholesterol at the level of our liver and other cells to manufacture all kinds of stuff for us. Instead of being a net depositor, let's be a net utilizer of the cholesterol that's there. So we got all these different statins. The most common ones we used down here are atorvastatin and rosuvastatin, because they are the ones that give us the most amount of LDL lowering, but there are these other molecules that are also available. Some people use them mainly when we can't tolerate these stronger kinds of ones, but most people are using these because our hope is to reduce cholesterol by at least 50% in order to have the positive effects on our blood vessels. Now, in addition to, or as a substitute for statins, there are other ways of kind of lowering cholesterol. We can take these sorts of medicines that block cholesterol from our gut. But remember that only about 25% of the cholesterol actually comes from our diet or is through the GI pathway. So these drugs are going to have a lower effect versus the statin kinds of medications. But sometimes we use them again combined or in place of the statin medications. And some of you may be familiar with, and a few of you may even be taking the newest family of cholesterol lowering treatments that are called these PCSK9 inhibitors. Now, this has the impossible name of that stands for this. They are known as injection types of therapies, and the way that they work is by allowing more recycling of LDL receptors. So on the surface of the liver cell, we have the ability of producing receptors that grab LDL particles and pull them out of the circulation. The PCSK9 inhibitors, when we take them by injection, allows for greater recycling of these receptors and reduction the amount of LDL that's kind of circulating around. And these products can actually reduce cholesterol also by 50%. So you can imagine if you combine a statin drug with these injectable PCSK9 drugs, you can get very dramatic LDL lowering to levels that are actually getting close to almost zero, which is quite amazing. And what's seen as a result of all of this is that we can reduce the chance of having heart attacks or stroke quite substantially by doing so. Okay. So cholesterol medications, in particular the statins, may also have side effects associated with them as well. And the ones that are kind of a nuisance might be muscle aches and pains. Now, we all get aches and pains at different times. They may be related to drugs, or they may be just related to life itself. And if we were together and asked you who has aches and pains, I would bet that most of us would kind of endorse that. If the muscle aches and pains are related to the cholesterol medications, here's what I ask about, or actually I look for with clients. That typically these aches and pains relate to big muscles. So the back, the shoulder, the thighs, as opposed to small muscles like the hands or something like that. Because the medications are in our system all day long, then I'm looking for side effects that are there all day long, as opposed to going for a walk and feeling an ache and a pain in the leg that lasts for a few hours and then goes away. That is characteristic of just kind of exertional use sort of discomfort, probably not cholesterol medication related, as opposed to something that is there all the time. And then occasionally trying to find the time relationship. So, if you had the ache and pain before you started the medication, then that's probably not related to the medication. And then sometimes we work through kind of periods of drug holidays where if you happen to stop the medication for a week or two and the ache goes away, then we've got some empiric evidence that they might be related to the medicine. I'm not telling you to do that. I'm telling you to have that discussion with your healthcare provider. And if that's what you decide to do, that's the pattern that we're looking for. Okay, that's cholesterol. The last thing that we'll talk about is how these arteries work. And normally they're under good control and they squeeze and unsqueeze. And that's the function of the lining cells here called endothelium, inside lining cells of the artery. And they're also under chemical control by this stuff that regulates how our vessels squeeze and unsqueeze. Squeezing and unsqueezing is normally a very healthy phenomenon, but sometimes we can squeeze too much. And when we squeeze too much, it's almost like your hands are together and shaking, and this denotes stress. And you may know somebody that does this. We have a hormone in our body that also governs this called angiotensin. If you try to dissect that word, angio we're familiar with as blood vessel or heart, and tense means tense, and sometimes we get too much of this. Very interestingly, we have this hormone in our body called angiotensin. And we can modify the amount of angiotensin in the body, because if we're doing too much of this, that's definitely not a healthy thing for our blood vessels, our blood pressure, or those arteries that are narrowed. So we can use medications that modify the angiotensin. ACE inhibitor drugs, you'll know them because they end in pril. And here is a listing of some of these drugs that are common, like ramipril or perindopril. They block the formation of angiotensin and allow blood vessels to relax. Their cousins belong to this family of medications called angiotensin receptor blockers. You recognize them because they end in sartan, candesartan, irbesartan, olmesartan, etc. So these are cousins of the other, and we often start with these. And if you can't kind of tolerate one of them, then we might switch over to the other. They work equally well in bringing down blood pressure, protecting certain organs of the body, smoothing out the blood vessels, and allowing things to relax. So that's the good part about them. There are side effects of the ACE inhibitor drugs, in particular the prils, and you may have a dry cough that goes through the night, or you may experience low blood pressure when you're getting out of bed. So take the time to move around slowly, because by relaxing these blood vessels, sometimes blood pressure will drop, and we just have to be mindful of these sorts of things. Okay. So we've gone through in the last 30 minutes different ways of dealing with this badness that can happen inside of our arteries. We can think about this cholesterol plaque and ways of reducing the amount of cholesterol by using various cholesterol medicines. We can think about the thrombus, the blood clot that's in the middle here, and think about aspirins or other kinds of medications to reduce the thrombus. We can think about ways of relaxing the blood vessel or relaxing the overall heart with beta blocker kinds of medications. Lots of territory. So if you have specific questions about your medications, then we want you to be familiar with this program called Meds Check in Ontario, that you can book an appointment with your pharmacist to go over your medications, what's good, what's bad about them, why are you taking them, are you on the right dose? And this is a service that is funded by the Ministry of Health to the pharmacists, and you can check in with your pharmacist once per year to sit down and go through this. Anyone that I've ever kind of spoken with that's gone through one of these appointments have felt that it's been very useful for them. Other kind of tips and tricks, keep a routine with your medications and avoid abruptly stopping them. If it helps, then getting them into a pack like this, a so-called blister pack, or using a medication reminder dosette container may be helpful, but try to take your medications around the same time every day. That can be very helpful. Gosh, in the day and age, one day we might be traveling again, certainly not now, but kind of planning ahead, and thinking about how we can keep our medications in a safe and convenient location. That will be very helpful. If you want more medications information, then we invite you to go to the Cardiac College website and look for the specific booklet about taking your heart medications and managing your condition very, very well. All right. And there is a Thrive video that is specifically produced around taking your medication. We'd invite you to go have a look at that. So at this point, I want to turn to some questions about your medications. And there's a couple of that have come in so far, but if you've got some other ones, please kind of add them into the Q&A box. Question number 1 is about use of a different kind of medication that we haven't talked about called dabigatran. It belongs to the family of medicines that are these anticoagulant drugs, even stronger than the aspirin or clopidogrel. That there are these other kinds of blood thinning drugs, and they are used by individuals that might have mechanical heart valves. or artificial heart valves, or with conditions called atrial fibrillation, where the heart isn't beating in a regular coordinated fashion. Usually the heart beats with the upper chamber, lower chamber, upper chamber, lower chamber. We're going to do a session later on, I think, about heart rhythm. But if the heart is not ejecting the blood, moving the blood really well, then sometimes there's a tendency for blood to kind of get pooled and it may clot for that reason. So we may be using stronger blood thinning medications like warfarin, dabigatran, apixaban, rivaroxaban to really thin out the blood. So this question that comes in from one of our kind of audience members is about use of dabigatran in the setting of an artificial heart valve. And there is guidance that one can find either on medical sites or on internet that sometimes we may prefer the medication called warfarin, or this older kind of potent blood thinning medication, especially if one has a mechanical or a metal heart valve, that warfarin may be preferred to dabigatran, one of the newer kinds of blood thinning drugs. So it depends on what kind of heart valve. If it's a tissue heart valve, then either one is quite okay. But if it's a mechanical metal heart valve, then warfarin may be the one that is preferred. So the question would be, quite appropriately, should one check in with the healthcare practitioner about this? And absolutely, do ask that question about which of the blood thinners might be best in your situation, and what is the reason for using that blood thinning medication. Is it because there is a heart valve issue, and is it tissue or mechanical? And the other question to ask is, what is the heart rhythm? Is it regular or irregular? And all of that will give kind of the best advice about which kind of blood thinning medication might I want to use. Question number 2 is about missing medications. This is a common thing for all of us. And, ideally we would be 100% on schedule with every medication, but all of us are human. And sometimes we will miss medications. If we can take the vast majority, like better than 80 or 90%, we're doing really, really well. So don't beat yourself up if you happen to miss one. Sometimes we'll recognize, gosh, I happen to miss one in the evening time or in the morning time. So what should I do? Should I catch up or should I just wait? So this is a question that comes up very regularly, and sort of the simple guidance that I might offer is that if you recognize that you've missed your pill and it's only been a couple of hours since you missed it, well, go ahead and take it. If it's been many hours or half a day, then you just might wait until the next one and catch up. It also depends on which medication it might be, that some pills have greater forgiveness than others. Like aspirin, for instance. Aspirin has a fairly long effect. It actually lasts for a few days. And if you're just taking a baby aspirin and you happen to miss one, well, leaving it till the next day is probably quite fine and won't affect things very much. But if you're taking a blood thinner drug like warfarin or Coumadin that we were just talking about, now that one has a very narrow window of effect and timing. So it's very important to try to take that very regularly on schedule. And if you happen to miss it, it really kind of messes things up. Cholesterol pills, very long action as well. Like I'm thinking like a couple of weeks at least. So if you happen to miss the occasional one, not so bad. And in fact, some people take their statin drugs every other day, just to let you know the duration of action for it. So it can be quite all right, and you have forgiveness, not permission, but forgiveness to wait some time or even to skip a dose if it's been a long time since you missed your medication. So hopefully that answers that question. The last one is around diarrhea or stomach upset. And is that particularly related to any of the medications in particular? This person is wondering if it's related to the drug clopidogrel, or its brand name is called Plavix, or a stomach pill called pantoprazole. So let me deal with these in turn. So in general, um, having stomach upset like diarrhea or heartburn or things like that, it's a very common part of life. And so if it's really medication related, then it would be something that would be persisting over the longer term as opposed to the occasional sort of thing. Now, having said that, certainly there are some medicines that can be associated with stomach upset, and it has been occasionally reported with the clopidogrel. So if it's something that started only after you started your medications and it's persisting and it's troublesome, then do discuss that with your doc, because there are alternatives to these sorts of things. The second medication called pantoprazole, its brand name is called Pantaloc if you happen to be on that one. It's used to reduce the stomach acid in the body and try to protect the stomach. It tends not to cause side effects like diarrhea. So of those two, I would probably look at the clopidogrel, but it is also quite possible that it's unrelated to the medications entirely. But it is something that you can chat about with your docs or pharmacists to see if it might be the culprit, because again, there are some alternatives potentially for them. Okay, so those are the 3 questions that came up in today's session. I hope that this, well, actually, there is one more just before we go, and let me look at this. Final one would be a good theme. So what do you do if you take an extra dose of a medicine? In this case, it might be a statin drug or something else that we might be taking, in this case, for prostate. And for the most part, not a big deal if you happen to take an extra one. The only one that I would really kind of be concerned about, again, if you're on one of those blood thinners like the warfarin, where taking an extra dose might actually lead to significant blood thinning, then that's the one I would be most concerned about. But typically a single dose is not going to be a big deal. You might end up thinking about skipping the next dose if you happen to double up. Okay, so great. Well, thank you very much for your attention and participation. Hopefully this has been of use to you. At some point, we may be polling you to say what are some other topics that might be of interest. We might also be connecting with you at some point to ask if this was a useful session for you. And we hope that it was. The next session that we'll be doing on Thursday is about exercising in cold weather. When it turns really, really cold, we'll want to find some indoor alternatives, but there are certainly safe ways of exercising in the cold. So tune in next Thursday at 7 p.m. for that session. In this series, a sister series is devoted specifically to topics for women. And the next Women with Heart Online series, men, you are welcome to join in, of course, for these, but on January 12th, that's actually tomorrow, that we'll be having a session about heart failure diagnosis and management, perspectives for women. So tune in again tomorrow if you have the time and interest. Again, thanks very much for joining in, and we'll look forward to connecting again through this series. And if you have any questions or comments, please feel free to reach out to your rehab supervisor and provide feedback or ideas for other topics. Okay, we hope that you all have a great day, and it's been our pleasure to join in with you today. Okay, take care.